Today we're really plunging headfirst into some critical hematology emergencies. You know, the kind of stuff that can be super confusing. Okay, let's unpack this. We've sifted through a ton of sources, critical care guidelines, hematology research, all to try and shed light on these complex diagnostic challenges. Imagine this. You get a lab alert. PT, 18 seconds, INR. 1.7, APTT, 72 seconds. Platelets are down at 80,000, fibrinogen's 108, D-dimer's elevated. So what does this all mean for a patient who's acutely ill? I mean, where do you even start?
Yeah, that's a great starting point because those numbers, they look alarming, but they don't tell the whole story. And what's fascinating really is how often labs like these can point in totally different directions. It really highlights why thinking beyond just the numbers is so critical.
Absolutely. So with these labs staring you in the face, how do you begin? Let's take something like the IST score for DIC. How would you apply that here?
Okay, right. Let's use the IST system. Platelet count, 80,000. That's a score of 1. Elevated D-dimer, that gives us 3 points. The PT prolongation, 18 seconds, that gets a score of 1 based on the system's application here. And fibrinogen at 108 milli-GDL, that's a score 0.
Okay, so add it up. 1 plus 3 plus 1 plus 0, that's 5.
Exactly. And a score of 5 or more on the IST scale suggests overt DIC.
So on paper, it looks like DIC. Pretty clear cut, right? But I suspect there's a catch. What's the trap here?
The trap is stopping there because you've hit the nail on the head. How can the exact same labs point to potentially 3 very different diagnoses? This is where that key principle comes in, something our sources really hammer home. Context is the king. It sounds simple, but forgetting it can lead to major errors.
Context is king. Love that. And to illustrate, you mentioned 3 clinical scenarios, all with these identical initial labs, but completely different final diagnoses. Let's walk through them. Okay, scenario 1, 62-year-old woman, post-op lap call. She's hypotensive, got tons of fluids, 6 liters of crystalloid, 2 units FFP. Abdomen's distended, confirms an arterial bleed, no petechia, no bruising.
Right, and with those identical labs, the diagnosis here is delusional coagulopathy. All that fluid just washed out her clotting factors.
Okay, makes sense. Scenario 2. Same age, female, but now she's got a bad upper respiratory infection. Looks like pneumonia, maybe empyema. She's got rigors, sweats, nosebleeds, confusion. Labs. Identical.
And here the context points strongly to DIC. The underlying sepsis is driving the coagulation system crazy.
Got it. In scenario 3, again, 62-year-old female, long history of alcoholism, jaundice, ascites, big spleen, some bruising, palmar erythema, pre-op workup labs. Identical again.
This time, it's chronic liver disease. Her liver isn't making clotting factors properly. Same labs, totally a different reason. These cases just scream context, don't they? One source puts it perfectly. Other conditions mimic DIC labs, most commonly dilution and severe liver disease. So the takeaway is clear. Don't diagnose DIC just in the lab sheet. Always look at the patient, the clinical picture, how things are changing. Use the scores, sure, but they support your judgment. They don't replace it.
That's such a critical distinction. Okay, so understanding context is paramount. Let's apply this. We have another case. A 25-year-old guy, healthy before, now a week of fever, getting obtunded, nosebleeds, purpura, chest x-ray shows a big effusion, they tap it, pus, diplococci, it's an empyema, his labs, PT18, APTT48, D-dimer high, platelets 40,000, high white count, HTT 47%. Now here's the dilemma. Surgeons won't drain the empyema until his coagulopathy is corrected. What's the right move?
Well, connecting back to what we just discussed, the absolute priority is to urgently drain that empyema. This perfectly illustrates the #1 rule of DIC management. Treat the underlying cause. You have to get rid of the trigger in this case, the infection, the empyema. Source control is key. You can't fix the downstream effects without fixing the source.
Right. It seems obvious when you say it, but in the heat of the moment, people fixate on the numbers, the PT, the platelets.
Exactly. Trying to chase the numbers without addressing the root cause is often futile.
So treat the cause first. What else guides DIC management?
Okay, beyond source control. #2 is supportive care. Fluids, oxygen monitoring, organ function, the basics, but crucial. #3, blood product support, but only if they're actively bleeding or need a high-risk procedure.
Okay, so not just based on the numbers alone.
Generally, no. The thresholds are usually platelets less than 50K, FFP for significantly prolonged p-ETT, cryoprecipitate if fibrinogen drops below 100, and PRBCs for symptomatic anemia or HB below 7. And finally, #4, avoid procoagulants like factor A or TXA unless absolutely necessary. You're dealing with a system that's already out of balance. You don't want to tip it further.
That makes a lot of sense. Okay, so DIC is this sort of chaotic activation, but what about other clotting emergencies? Let's shift gears to something different, where clotting is the problem, but the mechanism and the labs look quite distinct. Picture this. 49-year-old man, no major history, collapses suddenly, gets CPR, ROSC achieved, now in the ICU. He's confused. Labs. Hemoglobin 8.8, platelets are shockingly low at 7, but his INR, normal. LDH is sky high, indirect bilirubin up, haptoglobin gone, lots of cystocytes on the smear. Mild kidney injury, very high troponin, Takotsubo cardiomyopathy on echo, DID negative. What's going on here? Low platelets, signs of hemolysis, organ damage, but a normal INR. That doesn't quite fit the DIC picture we painted.
Exactly. That normal INR, despite the devastating picture and those incredibly low platelets, is the key. It strongly points us towards thrombotic thrombocytopenic purpura, or TTP. You see, in TTP, the problem isn't a widespread activation of the whole coagulation cascade like in DIC. It's more specific. It's caused by a severe deficiency of an enzyme called ADAM-MTS13.
ADAM-MTS13, what does that do normally?
It acts like molecular scissors for von Willebrand factor, or VWF. Normally, it chops up these large, sticky VWF multimers. Without enough ADAM-MTS13 activity, these ultra-large VWF multimers accumulate. These sticky multimers then grab platelets and form microthrombi, tiny clots in small blood vessels all over the body.
Ah, so that's the clotting mechanism. How does that cause the other symptoms?
Right. So red blood cells get sheared as they squeeze past these microthrombi, causing that microangiopathic hemolytic anemia, the low hemoglobin and the schistocytes, that's MAHA. The platelets get used up forming these clots, leading to profound thrombocytopenia, hence the count of 7 in our case. And these clots block blood flow, causing organ ischemia, the confusion from brain involvement, the high troponin and Takotsubo from heart involvement, potentially GI symptoms too, and crucially, these are platelet-rich clots, not fibrin-rich like in DIC. That's why the standard coagulation tests like INR and APTT are usually normal.
Got it. So different kind of clot, different lab pattern. Are there different types of TTP?
Yes, broadly 2 types. ITTP is immune-mediated, where the body makes antibodies against ADAM-MTS13. That's the most common type in adults. Then there's CTTP, which is congenital due to inherited gene mutations.
Okay. What are the classic signs and lab findings we should look for?
Clinically, neurologic symptoms are very common. Confusion, seizures, focal deficits, fever sometimes, bleeding or purpura from the low platelets, maybe chest pain or abdominal pain. Kidney injury is usually mild, which helps distinguish it from HUS, hemolytic uremic syndrome. Lab-wise, platelets typically under 30,000, often way lower. Low hemoglobin with signs of MAHA schistocytes, high LDH, high indirect bilirubin, low haptoglobin, DAT negative, and again, the key differentiator. PT, APTT, fibrinogen, usually normal. Creatinine, often normal or just mildly up.
And the definitive test
Is measuring ADAM-MTS13 activity. In TTP, it will be severely deficient, less than 10%. You'd also test for an inhibitor, the antibody, in suspected ITTP. But here's the critical point. Those ADAM-MTS13 results take time, often days. You absolutely cannot wait for the results to start treatment. TTP is a medical emergency.
So suspect it, treat it, but how do you differentiate it quickly from other things that cause MAH and low platelets? There are quite a few mimics, right?
Absolutely.
Yeah.
You need to consider other TMAs, thrombotic microangiopathies, things like HUS, often linked to E. coli, more severe kidney injury, complement-mediated HUS, drug-induced TMA, even severe infections causing DIC. But look for abnormal PTAP-TT, HELP syndrome in pregnancy, malignancy, mechanical valve issues.
Wow. Okay. Lots to rule out. Are there tools to help?
Yes, scoring systems like the PLASMIC score can be really helpful bedside. It uses readily available clinical and lab data platelet count, hemolysis markers, INR, creatinine, history of cancer or transplant to estimate the probability of severe ADAM-MTS13 deficiency. Our patient, for example, would have a high PLASMIC score, strongly suggesting TTP.
So high suspicion, maybe a high plasmic score. What's the immediate action?
Start plasma exchange, TPE, immediately, and high-dose steroids like methylprednisolone. That's the cornerstone of initial treatment for suspected TTP. Don't delay. You continue TPE daily until the platelet count recovers, usually above 150K, and the LDH normalizes for a couple of days. Steroids address the autoimmune component in ITTP. And newer agents like capilquizumab, which targets VWF directly, are also increasingly used.
Okay, TPE and steroid stat. That's a clear action plan. It really highlights how crucial rapid recognition and action are. Now let's move to another condition, one that presents like a thrombotic storm, rapid widespread organ failure. Think about this. A 48-year-old woman, history of lupus, SLE, and a previous DVT, starts with flu-like symptoms, then boom, within 24 hours, severe multi-organ failure. ARDS meaning ventilation, kidneys shut down, anuria, new seizures, altered mental status, and this characteristic skin finding, levator reticularis. Labs show platelets down to 75K, high D-dimer, some spistocytes, high inflammatory markers. What kind of storm is this?
This sounds very much like Catastrophic Antiphospholipid Syndrome, or CAPS. It's a rare but incredibly severe accelerated form of antiphospholipid syndrome. The defining feature is widespread small vessel thrombosis, hitting multiple organs almost simultaneously, often fueled by a significant cytokine storm, leading to that rapid multi-organ failure picture.
How does this happen? What's the underlying mechanism?
It often starts with a trigger infection is common, but also surgery, stopping anticoagulation, malignancy. In someone with underlying antiphospholipid antibodies, APL, this trigger sets off a cascade. The APL antibodies attack endothelial cells and platelets, promoting widespread clot formation. They also activate the complement system, adding fuel to the fire. It becomes a vicious cycle. Clots cause tissue damage and ischemia, which releases inflammatory cytokines, which then causes more endothelial activation, more clotting, more inflammation. It's just spirals.
A true thrombotic storm. What are the typical clinical features we'd see?
High fever is common, along with that rapid deterioration across multiple systems. Lungs often get hit with ARDS or hemorrhage. Kidneys with AKI, often severe enough for anuria. Neurologically, you can see strokes, seizures, confusion. Skin findings like levator reticularis or necrosis are characteristic. Heart attacks, bowel ischemia. It can affect almost any organ system. Hematologically, thrombocytopenia and sometimes MAHA are seen.
How do you diagnose something moving that fast? Are there specific criteria?
Yes, the Acherson's criteria are used for definite CAPS. You need involvement of 3 or more organs or tissues, developing rapidly, usually in less than a week. Ideally, you'd have histological confirmation of small vessel thrombosis, but that's often not practical acutely. And critically, you need confirmation of positive antiphospholipid antibodies, lupus anticoagulant, LA, anticardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. Often patients are triple positive, meaning all 3 are present.
So in our case, she clearly has the multi-organ involvement and rapid onset. We'd need to confirm the APL antibodies. What other labs support the diagnosis?
You'll typically see a markedly high D-dimer. Thrombocytopenia is common, usually in the 50-100K range, maybe not as low as TTP. An interesting finding is often a prolonged APTT due to the lupus anticoagulant. But paradoxically, this indicates a prothrombotic state, not bleeding risk. Inflammatory markers like CRP, ESR, ferritin are usually up. KPS is a great mimicker, often confused with severe sepsis, DIC, TTP, or other systemic inflammatory conditions like HLH or vasculitis. Clues like the Livs-Dido, history of thrombosis, or pregnancy loss, that prolonged APTT without bleeding, and maybe a known history of lupus or other autoimmune disease should raise suspicion.
How does it differ from, say, DIC or TTP in terms of labs?
Key differences. CIPS often has that prolonged APTT with a normal PT, whereas DIC usually prolongs both and has low fibrinogen. TTP typically has normal PTTT. The degree of thrombocytopenia can also vary. Management needs to be immediate and aggressive. It's often called triple therapy or even quadruple therapy.
Triple or quadruple? What does that involve?
It means hitting it hard from multiple angles. Full-dose anticoagulation, usually heparin initially, high-dose intravenous corticosteroids to quell the inflammation, and then plasma exchange, PLEX or IVIG, or sometimes both, to remove the antibodies and modulate the immune response.
Wow, pulling out all the stops. Okay, one more critical syndrome to cover. This one involves the immune system going completely haywire, often looking just like severe sepsis, but needing very different treatment. What happens when your sepsis patient just isn't getting better?
That's where you absolutely have to consider Hemophagocytic Lymphohistiocytosis, or HLH. It's a syndrome of extreme immune dysregulation. Think of it as the immune system stuck in overdrive. You get uncontrolled activation of immune cells, particularly T cells and macrophages, leading to a massive release of inflammatory cytokines, a true cytokine storm, which then damages multiple organs. It's life-threatening and frequently missed because it looks so much like overwhelming infection.
Is this something people are born with, or does it develop?
Both. There's primary HLH, which is genetic and usually present in childhood. But in adults, especially in the ICU, we're more often dealing with secondary HLH. SHLH. This is triggered by something else. Common triggers include infections, Viruses like EBV, CMV, dengue, HIV are notorious. Malignancies, especially lymphomas, or autoimmune diseases, where it's often called macrophage activation syndrome, or MAS, particularly in lupus or Still's disease. Certain drugs can trigger it too. Mortality is high if it's not recognized and treated.
So the immune system just goes rogue. What's happening at the cellular level?
Basically, the normal off switches for an immune response are faulty. Cytotoxic T cells and NK cells, which are supposed to kill infected or abnormal cells and then quiet down, fail to do so effectively. This leads to prolonged stimulation, massive cytokine release, especially interferon gamma and TNF-alpha, which then hyperactivates macrophages. These rampaging macrophages infiltrate organs, causing damage, and they also start phagocytosing, eating normal blood cells in the bone marrow and elsewhere, which is termed hemophagocytosis.
And how do these mechanisms translate into the clinical features?
It maps quite well. The organ infiltration by activated immune cells causes splenomegaly and hepatomegaly. The cytokines suppress bone marrow production, and the hemophagocytosis destroys existing cells, leading to cytopenias, low red cells, white cells, platelets. The hyperferritinemia, often dramatically high ferritin levels, is a marker of that intense macrophage activation. Hypertriglyceridemia and low fibrinogen are also driven by specific cytokine effects on metabolism and fibrinolysis.
How is HLH formally diagnosed? Is it just based on suspicion?
There are diagnostic criteria, the HLH 2004 criteria being the most widely used. You need to meet 5 out of 8 specific criteria. For ICU purposes, the most practical 5 are often 1. Persistent fever, 38.5 degrees C. 2. Splenomegaly. 3. Cytopenias, affecting at least 2 lineages. 4. High triglycerides, 265 mg/dL, and or low fibrinogen, 150 mg/dL. 5. High ferritin, 500 mg/dL, though often much, much higher in reality.
So when should an ICU team really start thinking about HLH in a patient who looks septic?
Key red flags. Persistent high fever despite broad-spectrum antibiotics. Developing or worsening cytopenias. Splenomegaly. Rapidly progressive multi-organ failure without a clear infectious explanation. And especially that sky-high ferritin levels over 3,000 or even 10,000 GL are highly suggestive, much higher than you typically see in uncomplicated sepsis. If the sepsis picture just isn't adding up or responding appropriately, think HLH.
Let's apply that. Consider a 30-year-old man, previously well, now with persistent fever, worsening respiratory failure, bilateral infiltrates, but no clear infection found. Labs show ferritin is 14,200, triglycerides 380. He has anemia, thrombocytopenia, leukopenia. Ultrasound confirms splenomegaly. Fibrinogen is 68. Bone marrow shows hemophagocytosis.
This case screams HLH. Let's check the criteria. Fever, yes. Splenomegaly, yes. Cytopenias, yes. All 3 lineages. High triglycerides, low fibrinogen, yes. Both. High ferritin, definitely yes. Hemophagocytosis on marrow, yes. That's 6 out of 8 criteria easily met. There's also a scoring tool, the HScore, which incorporates things like immunosuppression status, temperature, organomegaly, cytopenias, ferritin, triglycerides, fibrinogen, LDH, and marrow findings. This patient score would be extremely high, like 258, giving a 99% probability of HLH.
So once HLH is diagnosed or strongly suspected, what's the treatment? It sounds like antibiotics aren't the answer here.
Exactly. The treatment is immunosuppression, aimed at calming that cytokine storm and shutting down the overactive immune cells. First-line therapy typically involves high-dose corticosteroids like dexamethasone. IVIG is often used, especially if an infection is the suspected trigger or an MAS. For more severe cases, or if associated with EBV infection, the chemotherapy agent etoposide is added. It specifically targets those hyperactive immune cells. Anakinra, an IL-1 receptor antagonist, is another option sometimes used. Treatment needs to be tailored based on the likely trigger and severity.
What an intense deep dive. We've covered DIC, TTP, CAPS, HLH, conditions that can look similar on the surface but are fundamentally different underneath. It really drives home that labs are just one piece of the puzzle, isn't it? Context, clinical picture, careful differentiation, they're everything.
Absolutely. If there's one thread connecting all of this, it's the critical importance of clinical context and thinking beyond the numbers. Medicine isn't just pattern recognition from a lab report. It's about integrating every piece of information about the patient. So the next time you face a really complex situation, maybe not even in medicine, maybe in work or life, think about these syndromes. Consider how easy it is to be misled by surface data if you don't dig deeper and ask why. And maybe a question for you listening. How can applying that context as king principle help you tackle other complex problems? What hidden factors might you uncover if you look beyond the immediately obvious?